Laparoscopic surgery, also known as minimal access surgery, allows for an operation to be conducted through a series of small incisions. This is seen as a modern alternative to classic/open surgery through a larger incision. There are 3 ways of gaining access to the human body: through a natural orifice, an open/large incision, or with a camera using a small surface incision. Before the advent of camera and transmission systems, all surgery was open. You could only operate what you could directly see in front of you. Laparoscopic surgery is a means of operating through a series of smaller surface incisions to obtain outcomes comparable to open surgery. The points of incision on the skin are sites of access to the abdominal cavity. A metal or plastic tube, trocar, is placed through each of the skin incisions, traversing the abdominal wall. This provides a tunnel from the outside to the inside of the patient. It is sealed at the outside with an airtight valve. Through these tunnels/trocars, instruments can be placed into the abdomen. Visualization and lighting is achieved by passing a camera, laparoscope, through the trocar in the belly button/umbilicus. In order to create space in which to work, the abdomen is inflated with a gas, carbon dioxide, which distends the abdominal skin, expanding the space in which the surgeon can operate. The first trocar inserted into the patient is at the umbilicus, belly button. This is a blind procedure, without visualization of the abdominal cavity. Through this, a lens and illumination/light system, laparoscope, connected to a camera is inserted. Laparoscopic instruments have similar functions as instruments used in open surgery. Graspers and scissors are common to both, except in laparoscopy, these instruments have much longer shafts to allow them to pass from the outside to the inside of the patient. The surgery is performed using these specialized instruments placed through the trocars. This allows a complete and comprehensive range of surgery to be performed without the need for large abdominal skin incisions. Multiple ports/trocars allow for two-handed manipulation and surgery by the surgeon and for the assistant to assist in the procedure. The umbilical/belly button port with camera inserted is shown below the red arrow. The additional/operating ports for the instruments are indicated by the yellow arrows below. Below is a closer view of the trocars/ports on the abdomen. Below is a typical layout of the theater, including the position of the surgeon, assistant, scrub nurse, and anesthetist during the surgery. Throughout the entire surgery, the exposure of the patient is kept to a minimum. The patient is covered with sterile drapes, with only the necessary areas of the abdomen exposed to allow for the placement of the operating ports. The camera system provides a magnified, high-definition, 4K resolution image on a monitor in theater. Surgery is performed watching the monitor. A normal female pelvis is shown below with the uterus arrow, fallopian tubes, dotted lines, and ovaries O indicated. This is the environment and space in which laparoscopy takes place. What are the advantages of laparoscopic surgery? When laparoscopy is compared to open surgery, laparotomy, there was a lower rate of 8.9% compared to 15.2%, with the data showing a relative risk of 0.60, 95% CI equals 0.50 to 0.70. There is no statistically significant difference in the risk of major complications like bowel or vascular injury. These events remain rare, occurring at an identical rate in both groups, 1.4%. Shorter hospital stay/admission, less pain, faster recovery, and return to normal levels of activity. What are the risks associated with laparoscopic surgery? Anesthetic risk. All laparoscopic surgery is performed under general anesthesia. This is a combination of sedation, ensuring you are not conscious and therefore pain-free, and muscle relaxation, ensuring a relaxed abdominal wall. The muscle relaxation prevents breathing, so air and oxygen must be provided throughout the operation via ventilation. The air reaches the lungs via plastic tube placed through the mouth, into the trachea, tube entering the lungs. This pipe has an inflatable cuff, which seals off the trachea, reducing the chances of any stomach contents reaching the lungs. To assist in reducing this risk, you will be asked not to eat meals or drink fluids from 10 o'clock in the evening prior to your scheduled surgery. All anesthesia is associated with some risk. This will be addressed specifically with you by your anesthetist. Since there is no surgery without anesthesia, all surgery starts with the assumption of this risk. Major complications. The overall risk for a major complication at laparoscopic surgery is low 0.5 to 2%, or we can say 1 in 200 to 2 in 100 cases. As indicated, this is no different from the risks associated with open surgery. Abdominal entry risk. When we enter the abdomen, this carries the potential risk of bowel, intestinal, or large blood vessel injury. These are the two major possible injuries associated with laparoscopic entry. Although the absolute risk for such an event is low, the severity demands that they be addressed. It is important to realize that while distressing, this risk is inherent to all laparoscopic surgery, regardless of the type of entry technique. Currently, no entry technique has been shown to be superior to another. The quoted figures for bowel and vascular injury are based on quoted figures in medical literature. These overestimate the risk associated with an experienced laparoscopic surgeon. With experience, the risk is reduced over that seen with a novice. There is no level of medical experience which can guarantee surgery to be risk-free. Just like driving a car, experience improves safety, but that doesn't mean you cannot be involved in an accident. Risk of bowel injury is about 1.8 out of every 1,000 cases. Risk of vessel injury is 0.9 out of every 1,000 cases. Risk of bladder injury is 2 to 3 out of every 1,000 cases. Conversion to open surgery is 7 out of every 1,000 cases. The risks of bladder and bowel injury and the risk of conversion to an open procedure are influenced by several factors. Prior history of surgery, previous intra-abdominal sepsis, severe infection, for example, previous burst appendix, previous bowel injury, conditions associated with an inflammatory/adhesive response, for example, endometriosis, uterine fibroids. Your prior medical and surgical history is important to us. It is important you complete the information forms as accurately as possible, and where relevant, update the information when indicated. For example, a new surgery since your last appointment. Minor complications. The overall risk of a minor complication is 1 to 5%, 1 to 5 in 100 cases. Shoulder pain. The carbon dioxide gas which is used to distend the abdominal space, peritoneal cavity during surgery, can irritate the diaphragm. This leads to what is termed a referred pain, pain experienced in a different location to the initiating cause. In the case of diaphragmatic referred pain, this is experienced as shoulder pain. This is brief and self-limiting, will disappear on its own without any treatment needed. Skin scarring. All laparoscopic surgery requires skin incisions for the insertion of the trocars/ports as described above. Generally, these incisions are placed within the umbilicus/belly button and on the lower abdomen as indicated below. These tend to leave very small scars. There are, however, patients who will experience excessive scarring. This can be genetic, keloid formation, or exacerbated by wound infection, smoking, underlying uncontrolled diabetes, obesity, excessive early exercise. If you are specifically concerned about scarring or have had prior surgery which has produced excessive scarring, kindly discuss this beforehand with your treating doctor. Bleeding. Bleeding from any of the incision sites is possible. Most often this can be solved using a pressure dressing/plaster. In rare cases, a small suture may need to be placed to stop the bleeding. Fluid leakage from the wound. Occasionally your surgeon will leave fluid in the abdominal cavity, called a hydrofloat, to reduce the chances of postoperative adhesion formation. This fluid may leak through one of the lower skin incisions immediately postoperatively. Should you observe this, kindly inform the ward sister to change the dressing and confirm with your doctor if a hydrofloat was used. This is self-limiting, will disappear on its own with no specific treatment required. Wound infection. It is essential to keep all the incision sites clean and dry. Should the dressings covering the incision sites become wet from bathing or fluid leakage or blood-stained from bleeding, then please remove the dressings, clean the wound with soap and water, and reapply clean, dry dressings to the incisions. Replacement dressings are often provided and can be bought at your nearest pharmacy in the event you require more. If you are unable to obtain the appropriate dressings, rather leave the incision sites open to the air than covered by a wet or blood-stained dressing. Patients who smoke, are obese, and who have poorly controlled diabetes are more likely to have wound infections. Kindly discuss this with your doctor prior to the surgery. Be alert to any signs of wound infection, swelling, redness, localized pain, increased localized skin temperature, any oozing from the wound. If any of these signs are seen, call Vitalab immediately on 0119-1147-00. You will be accommodated for an emergency appointment with the first available doctor. Pain over a port site laparoscopy is associated with less pain than open surgery. If you have had fibroids/myomas removed or large ovarian masses, this will typically be removed through the left or right-sided lower abdominal port site. When a trocar larger than 10 mm has been used to facilitate tissue removal, the rectus sheath is closed with deep sutures at the relevant port site. In these cases, it will be normal to have increased pain over one of the lower port sites. If you are concerned, discuss this with your doctor to confirm this was the port site used for tissue removal and closed with deep sutures. This is self-limiting, will disappear on its own with no specific treatment required. Usually, one of the lower lateral port sites is used to remove tissue from the abdominal cavity. In these cases, deep sutures are placed at the relevant port to reduce the chance of hernia formation. These deep sutures can lead to a deep pulling sensation, which will gradually ease and fade away. Overall, laparoscopy is seen as a modern means of obtaining access to the abdominal cavity. It is associated with half the overall risk of complications compared to open surgery, with significantly less pain and faster recovery. This information leaflet is not meant to scare you, rather to equip you with information to make a better and informed choice. If you have had laparoscopic surgery before and were not aware of the risks, it is not because the risks did not exist, rather that they were not discussed. As always, should you have any specific queries regarding your planned surgery, kindly discuss them with your treating doctor. Our surgery is elective, except for ectopic pregnancies, and you should take the time necessary to be comfortable with the planned procedure and explore any queries beforehand.